Good afternoon, everyone. Welcome to the panel of Delivering Healthcare in Rural America. My name is Anthony Daniels. I have the pleasure of serving as the Alabama House Minority Leader and a member of the One Country Board of Directors. Delivering rural healthcare and ensuring rural residents have ready access to care for priorities is a priority of mine. And in Alabama, we've seen approximately 17 hospital closures in the last 10 years, which shows that there's a significant impact of rural America within the state of Alabama and across the country. And so let me begin by introducing our esteemed panelists for today to start this conversation. Ebanola Akia Kaye is the Assistant General Counsel and Senior Director of Policy and Regulatory Affairs at Homeward Health. Homeward Health is a technology-enabled healthcare provider delivering healthcare for those who don't have it, starting in rural America. Donald May served as the Federation of American Hospital Liaison to the Center of Medicare and Medicaid Services, as well as Medicaid Payment Advisory Commission and the Medicaid and CHIP Payment and Access Commission in addition. Don supports federal policy and legislative initiatives on Medicare and Medicaid, the Affordable Care Act, and managed care and quality. Carolyn Mayle serves as the Vice President of Government Affairs for the Air Methods Corporation, the largest emergency air medical provider in the country, overseeing government matters impacting the company. She has over 25 years of legislative, policy, and political experience with a primary focus on healthcare, and has held major positions in trade associations and Fortune 50 corporations in the Washington, D.C. area. So we'll begin this panel. We'll begin with Ms. Ebanola to have a discussion about a recent poll. A recent poll showed that the vast majority of rural residents like their rural hospitals and wanted to remain open. However, hospital closures have been a significant issue in many rural communities. What do you think could be done to make rural hospitals more profitable and ensuring that they remain in operation?
So I will humble myself and say that I am not the expert in profitability for rural hospitals. But what I will say is that as providers, what we do know is that it has to be collaborative, right? It has to be everyone in the communities working together in order for us to maintain and improve the care for those who live there. And so thinking about providers, whether it's us helping with discharge and making sure that we support the rural health systems to the extent that they need, because they may not be able to check on individuals who may have been discharged from the hospital, and making sure that their care is better. What I will say is it takes everyone in.
We can go to Donald at this particular time, and then we'll hear from Carolyn.
Happy to, and just wanted to start by thanking you for your leadership of this panel and the group for having us today. I'm with the Federation of American Hospitals, and we represent roughly 20% of tax-paying hospitals in the United States. Many of them are rural, and we understand the importance of rural hospitals in their communities. For me, I grew up in Southern Ohio, in a county with one small rural hospital, that was really the hub of healthcare in that whole community. And it really allowed the limited industry that was there to be there. And so firsthand, I understand the importance of rural hospitals. When we look at rural hospitals, the financial challenges that they face are real and significant. Some of that has to do with the challenges of being in a less populated area and not having lots of volume and lots of cases coming in the door. Some of it has to do with those structural problems with the way they're reimbursed by the Medicare program, for example. And there are a number of proposals that we believe could be implemented that would increase the reimbursement for hospitals, rural hospitals under Medicare, that would make them more comparable to urban hospitals and would improve their margins. Right now, most rural hospitals, and in aggregate, hospitals lose money treating every single Medicare patient that comes in the door. For a rural hospital in lots of rural areas, Medicare is the primary payer. So if you're always losing money on every single patient that's walking in the door, how do you make it as an organization and sustain what is needed in the community to really support that? Now, we have a number of proposals that we think could be helpful, providing a floor on the hospital wage index. That's what determines how one hospital in one community is paid more or less than a hospital in another community. And that wage index typically pays hospitals in like New York City more than it does in probably rural Alabama. So we don't necessarily think that the hospitals in Alabama should be paid the same as in New York City, but we know they're being paid too little. And so if you put a floor or a minimum payment amount on there, that would help the financial situation tremendously. There are other issues related to how hospitals are reimbursed by Medicare for treating the poor. And you could increase those payments. Right now, there are rural hospitals that don't qualify for the same types of payments that urban hospitals would have. And so there are rural, we call it disproportionate share payments, that could be equalized in a way that would support rural hospitals and their financial situation. But again, the problem we have, and it's one that we have to address, and I know Medicare funding and Medicare spending is one of the biggest challenges that we have with the federal budget. But if every Medicare patient who walks in your door is a case that the hospital lose money on, ultimately, it is not a situation that works in the long term to maintain access in rural America.
Carolyn.
Hi, thanks for the opportunity here to speak today. As you mentioned, we're one of the largest emergency air ambulance providers in the country. And, I have to agree with what, Donald said. The Medicare reimbursement challenge is a huge issue across the board, I think, for many healthcare providers. And, we support policies to help preserve and, buttress the rural hospitals. We obviously have legislation that we're supporting too to help increase the Medicare reimbursement for air ambulance providers. But, what we've been seeing with the rural hospital closures and the restriction of, certain services, specialty physicians in those rural hospitals is that we are actually busier than ever. And it's putting a huge strain on our system too, because, we're doing more emergency air transports from these smaller rural hospitals or facilities to the larger hospital facility that can care for them. So we do support, ways to help support rural America and rural hospitals, because I think it's, it's really causing strain on the emergency medical system. So I think, if we can fill those gaps and support that, that also helps relieve some of the pressures that the emergency air ambulance community is also experiencing right now. But I agree wholeheartedly. When you have the majority of your transports or majority of your patients are Medicare and you're getting under reimbursed, and that's not even talking about Medicaid, we have a big challenge ahead of us.
I agree. We've been experiencing some of that here in the state of Alabama, as I mentioned before, about the 17 hospital closures that we've experienced, and a lot of other hospitals that are on the brink of closing. And one of those issues that we have here is that we did not expand Medicaid. And so we've been trying to find a healthcare solution to working around the politics within the state that we're working closely with insurance companies like Blue Cross and Blue Shield to try to find a solution to the issues that we're having right here within the state of Alabama.
So I obviously agree with everything that has been said. And I think what I should do is take a step back and sort of talk about who Homeward Health is first before talking about our perspective. So Homeward Health is an in-network provider focused on increasing access to care to those in rural communities. And to do that, what we do is we partner with health plans who have Medicare eligible beneficiaries. And what we do is we use a value-based care model. And that what that means, fancy word for saying, is that we are allocated an allotment of patients, and we are given an amount of money to take care of that patient in the long term. And so our priorities are making sure that that patient is healthy in the long run because of the value-based care arrangement that we have. And our CEO CEO is from Winona, Minnesota. And so that is the town that she wanted to serve and the individuals and the neighborhoods and communities she wanted to serve. And so we focus on rural communities, and we have been in operation for a year now and in 2 states. And so for us, it's all about collaborations, right? What I think we have learned is those who've been in the trenches for years and doing the work know what they need. And so for us is like, how are we a value add and how can we support, whether that's supporting legislation, whether that's supporting the local hospital systems and the communities we go into. It's been a huge focus for us because obviously primary care physicians, nurse practitioners can't do everything, and they need to have a hospital to go to the extent that anything goes wrong or if they need more care. And so for us, it's sort of that partnership of what can we do from the provider level to support our hospitals, because for many of the communities we serve, that is the lifeline. And so for us, it's building those communities and supporting our rural health systems to the extent that we can lend our voice as providers on the importance of how great they are and how important and vital they are for the communities that they serve.
Thank you. And thank you, guys. Thank you for what your company is doing to really change lives in rural America across the country. And so we certainly appreciate you. We know that the Department of Veteran Affairs have been working to expand access to healthcare care facilities. However, like the first question, there are many issues with billing and access that still remain. What do you guys think the immediate obstacles to delivering better care for veterans, and what policy solutions would you recommend to improve access? And we'll start with Carolyn for this question, then go to Donald, and then Abano.
Yeah, thank you. So the VA is an important partner to Air Methods. Last year alone, just with veterans, we transported over 1,400 veterans. And they're also there for those veteran communities in case they need the service. It's a very rare service, obviously. Also, another reason why it's important is 30% of our workforce are veterans. We're helicopter pilots, we're clinicians. A lot of these people come from the military and they like the environment and the world and helping more people in these emergency situations. The challenge we have right now is the VA has proposed changing the reimbursement of how they pay us, which is currently paying more at market rates, and going to Medicare, which would be great if Medicare actually paid us closer to what our costs are. But the challenge is that our Medicare reimbursement right now hasn't been updated in over 20 years, 22, 23 years. I've been working on this issue for a while, so the years keep going. And so, the Medicare reimbursement pays less than 50% of our costs. And so tying it to Medicare really doesn't make sense. And what our concerns are is if they go forward with this rule and this reimbursement change, it's really going to hurt veteran access to air medical. And we'll have to close bases. And we already have closed bases and particularly most of these bases are in the rural parts of America because that's where, the payer mix, Medicare, Medicaid, lower income people tend to live. So we've been working a lot with VSOs, veteran service organizations, who all support delaying this rule and not doing this and tying it to Medicare. And so, our whole thing is for a policy change is saying, look, hold off, do not put this policy in place because you're going to hurt veteran access. Instead, why don't you wait until we have updated the Medicare reimbursement rate, which also is something that's in the works right now with legislation on the Hill. So those are some of our concerns, but we really think that if the VA can delay these cuts, that's really going to help preserve this access because this is, obviously a constituency that should always have access to the best health care.
And I agree. We certainly, I didn't realize it's been that long. You said 50 years.
No, sorry, over 20 years, 22,
over 20
23. I keep dating myself because as every year I work on the issue and it keeps going. We're like, oh, now it's been 24 years. So, but it's been a long time. I think it was 2002 is when they put in the Medicare fee schedule for air ambulance. And it really hasn't been updated since then, except for small inflationary updates. And as we all know here, inflation has been a little higher over the past few years and not really keeping up with actual costs. So, and obviously a helicopter today is a lot different than 20 years ago.
I agree. And we hear from other providers that are offering services about, how the increase in cost and their overhead from a supply standpoint with the reimbursements at the same level. And so I certainly understand that. And we hear from providers all the time about that particular issue. Donald.
On Veterans Affairs, I think, whereas ambulance providers will move patients from somewhere else to the Veterans Hospital or out of the Veterans Hospital, I think we are oftentimes in a rural area competing against Veterans Affairs for the same workforce. And I think we definitely want to have access for veterans in those areas, but I do think we can think about future policies where there's maybe more shared delivery, better communication between veterans hospitals and the rural hospitals in those areas and other hospitals in general to make sure that the coordination is going back and forth, especially when a veterans facility may not be providing all of the hospital level services, maybe doing more outpatient services. So improving that coordination across those providers, just knowing the shortage of workers in rural areas, improving that kind of coordination, we believe would help to improve access for veterans who are receiving their care in rural America.
Evanola?
And the only thing I will add to the conversation is, as Donald said, more of the care coordination. So we have a lot of veterans as our population of beneficiaries, and so we work with them more on their supplemental insurance, whatever that may be. And so for us, it's more of the care coordination, just making sure that we have the information we need from the VA. And making sure that we're able to coordinate their care to the extent that we're needed for a service that they may not be able to do. And so for us, that's more of the issue of to Donald's point, all of us working together to get everything we need in order for us to provide care for our patients.
Thank you. And so the next question is, mobile clinics and even home visits have been used by some primary care providers to cover access gaps in rural communities. Is enough being done to support programs like this, or could insurers or the government better support access from those channels?
You probably should start with Evanola because she probably knows more about this than I do. But I really do think that there can be more done. And when you think about access and ability for people in remote areas to gain access to healthcare, using mobile and home visits is a really good way of integrating care, making sure there's follow-up care and coordination. And I think that those types of services are really important to integrate with the hospital services that they've received, in particular with follow-ups. So, one of the things we learned with the pandemic is that there are better ways of providing care that can break some of the traditional molds. And mobile health and home health, especially when combined with telehealth, I think we've shown can be really effective. And when all the providers are connected in that way, and you're following up care, making sure that patients are getting access, especially if they may have transportation issues or no one at home to be able to take them somewhere, those types of services can really improve outcomes. And finding policies that support that for Medicare and private payers and Medicaid, I think are going to be critical in the future, especially in rural America.
Evanola?
Yeah, no, this is finally my wheelhouse, but 100%.
You're doing a great job either way.
I co-sign on everything that Donald has said, and of course, there's always room for improvement. I think I am encouraged by last congressional session. There was the Mobile Health Act, which extended the use of mobile clinics for community health centers, because as Donald said, this is very important for areas where it may be tough for them to get to the nearest hospital. What we found is if it takes too long to get to the hospital, you do a 30-minute meeting and then they have to drive an hour back. It reduces the amount of follow-up that they will do, because one of our beneficiaries said they had to pay someone to take them into town. And so what I think would be helpful, at least on the mobile clinic forefront. This is me being like a lawyer, just acknowledging that these models exist and using them to their fullest capacity. I think before COVID, when you think of mobile vans, traditionally it's like, well, doing dental screenings or a mammogram or very specific services that were done in mobile health clinics. And so when you look at different states, there's all these rules and this is how you do it. And, this is how you can receive a license for, these services. But then let's say you want to do a primary care, just a general primary care mobile clinic, there are no rules. And then you're like, it's not a hospital, it's not a physical location, we don't do dental. And so I think this is more so on the state level. It's just an acknowledgement that we have gone through this pandemic until Donald's point. We have seen how we can use these and bring these this access to care to communities. And so an acknowledgement that this exists and sort of an expansion on how we use those mobile clinics, and so that they are acknowledged when you're trying to fill out forms, right? And they say physical location and you say, well, it moves. So just little things like that, like operational things would help as it relates to mobile clinics. And I think as it relates to home visits, it's in reimbursement. We do a lot of our work and we chose value-based care because it provides us the flexibility for us to do things that fee-for-service would not pay us to do. So for example, if you do a home visit, of course, rural communities, it takes you an hour to get out there. There's no code for that, right? The travel time that you have to get to a patient's home. And then even on top of that, the in-home visit is usually reimbursed, at least in the fee-for-service model, less than an office visit, right? And so it makes it hard for providers to want to use that option, right? That is available, but it's just not reimbursed in a way that is beneficial for them. And so for us, what we're using is hopefully more value-based care models are created whereby we take full capitated risk. So at the end of the day, everything we do, right, whether it takes us an hour or two, or whether we're talking more, getting to a place where we have built trust with our patients, like we can do that because we have the allotted fee. And so it gives us more of an availability to be innovative. And I think as it relates to commercial insurers, Medicare and Medicaid, is acknowledging that we do have to sort of move away from a model where it is just this one thing and you get a payment for your one service. How do we think about this type of model, incorporating this type of model as well, where you can spend a little bit more time with the patient. You can go to the home and it won't be less money, right? Because it's better for the patient. And so by no means do we have the panacea of what that looks like, but an acknowledgement of that type of care would be helpful as we're trying to navigate what we've learned from the pandemic and trying to implement it on the other side.
Thank you. You certainly do have a lot of knowledge in that area. So it have me excited. So next, Carolyn.
I will defer to the experts here on the mobile clinics and home visits. I would just say that, there's always more than insurers can do covering things. But when communities don't have access to primary care health providers and they can't get access to them, particularly in these rural areas, I mean, having policies that take into account and are more creative and thinking out of the box is what needs to happen. And unfortunately, insurers and government are always behind the ball and figuring out how to cover these things. So, we just, insurers to start, since they're the ones that usually can begin with the coverage, need to be more nimble and more understanding of this is how people need to get the care they need, because otherwise they have more complex conditions after the fact, and that's where we come in. So it all makes perfect sense, and I think these policies should be put in place to reflect that we have a very diverse communities out there, and rural America needs different things nowadays.
Absolutely. And so that brings me to my next question. What's the role of telehealth? What role does it play in filling the coverage gaps in rural areas? And can it be an effective alternative to in-person visits for routine health issues? And so we'll start with Abanola on this one.
Sure. Telehealth is obviously one of the models that we use. And it's, to your point, it helps with transportation, right? To the extent that we have a beneficiary who's out in a rural community and they have broadband access, and I'll talk more about broadband access later, to use the live audio. It really helps. It also really helps because as we've all noticed, there are provider shortages, right? You may need to talk to a specialist, right? And so having that option has been great for us, and it expands the access of care. So someone who may have taken them 2 hours or an hour and a half to get to the local clinic, if they can say, oh, I can see my same doctor and I can see them in live audio video, then that is like transformative, because they have not, taken off work, right? Loads of time just to get to a hospital visit. And so for us, I think telehealth has been amazing, because it has been one of those things that has broadened the access to care. And then also, telehealth helps with remote patient monitoring, right? And so if you have a patient that they're not quite sure, is their blood pressure too high? If the doctor can see that, right, because they have the remote patient monitoring devices, right, they can do a call in and say, hey, you may need to come in, or you may need to get to the hospital because your blood pressure is too high. And so I think it's been transformative. What I will say, it is not the panacea, and I don't think it replaces in person. I think it's an add-on. It's something that you can use. Our perspective is, obviously, when it's clinically appropriate, you use telehealth. So not everything is going to work for telehealth, but to the extent that it's clinically appropriate, you should use it. But I think what's interesting is we talk about telehealth, but as you all know, we serve rural communities, and not all of them have broadband access, right? And even though there has been legislation and money afforded for broadband access, you cannot create a whole grid or a whole telephone network or internet network in a day, right? And so what we have found that has been very useful for us is audio only services. And we have found that for some of our population, that they don't deem it as less quality, right? Not as good as a telehealth live audio video. And so at least for us, we are, pounding the metal and telling everyone that, okay, audio only may not be for everyone, but for our population, this is a tool that we would like to continue to use because we've seen for some of our beneficiaries that they may not have live audio video, or you may be doing a live audio visit and it cuts in the middle. So I can't bill for that, right? So I have no option, right? I got to do a whole nother visit, or we have to, find another time. And so, as much as we talk about telehealth, it would be remiss of me not to say that there are individuals in rural communities who can't even use the live audio video. And so to make sure that we address that population is making sure that we can, and that means government and as well as commercial insurers, noting that audio only can be a viable option to the extent that it's clinically appropriate for those who just don't have the access to live audio video. But it's been great. And of course, everyone in the space hopes that the flexibilities don't end, particularly in Medicare. And so I think all of us are telling our congressmen and women, don't leave us hanging. We can't just go back to what it was before. And so it's been great. But I do want to harp on that there are groups and communities in rural environments who can't even use a live audio video. And so audio only, it may not be technologically fancy, but it is one way to also broaden access to care.
Thank you. And I agree. In some of the areas, even particularly here in the state of Alabama, we've had those challenges, and COVID kind of exposed those vulnerabilities in our communities across the state, and not having the appropriate infrastructure to ensure that families have access to broadband access. And so that digital divide is real, and we certainly have to focus on that infrastructure. But you're right, we don't need to go backwards. And so I certainly appreciate you saying that. Carolyn.
So due to the nature of our business, we don't provide telehealth services, since typically when the patient's in our helicopter, they're dealing with some really serious condition, and we're trying to either keep them alive or provide additional services, provide blood, those types of things, do ECMO. It's amazing what you can do in a helicopter nowadays. But obviously it's extremely important. As you mentioned, telehealth is just one piece. There's a lot of different pieces that are important in rural America. But I would just be remiss if I didn't mention, something else that's sort of more in the beginning stages. But we have a part of our business that's looking more towards how do we make sure we can get supplies to facilities or physicians or whoever's in these rural areas in a much faster way, because right now, just for example, this is a statistic, in rural areas medical supplies are delayed an average of 37 days more than in urban areas. 69% of healthcare providers have delayed care due to lack of supplies. And so we have a business that we've invested in that's basically the drone business, commercial drone business. And this is a business where in the rural parts of the state, we're planning and starting to use it where we can bring supplies from one hospital to another, or different things they need. In this way, that nurse doesn't have to leave and drive 2 hours and not be there at the facility to take care of that patient, and so they're going to bring these drugs. And so we're saying there's better ways to do this, and this drone business is really where we're hoping to go in certain parts of rural America where you just need to get some additional assistance. And so that is something that we hope that will minimize the day-to-day challenges that rural areas have. There obviously right now, since it's a new technology, there's numerous regulatory barriers. We're working. This falls more in the FAA kind of airspace. So we're working a lot with DOT, FAA reauthorization this coming year to start removing some of those barriers to allow, whether it's interstate, different states, whether it's also carrying certain types of, drugs, or if it's, in airspace. It's amazing how many laws have been put in place that never realized there was going to be this type of technology where you could actually deliver the care this way.
Thank you. Don?
I think, as Avinola said, telehealth kind of changed everything during COVID, and it became a much more utilized, but I think people saw a promise there. And like both of you said, no one wants it to go away now. And I think initially there were some hospitals and maybe probably physicians that were kind of concerned about that. What would it mean for compliance and complications with billing? But what we found was it was very effective. And I think hospitals use it in a number of ways. We can bring in a specialist from a city that may not even be close by. It could be clear across the country, to be able to consult on a patient that you could never bring that specialist to a rural community because there just aren't enough patients there. There just aren't enough people, let alone patients. And you can bring that kind of expertise in hospital to hospital kind of telehealth. And that happens, and we want to continue to use that. But being able to communicate with patients after discharge to prevent readmissions, because so many patients won't come back in for a follow-up. And if that patient needs to go to a physician's office or to a hospital for that kind of follow-up, they're not doing it. So this is a tremendous way of gaining that. And so we definitely see the value of it. It's added a lot. I think one notion to think about, though, is that during the pandemic, hospitals actually provided hospital care in patients' homes. It was called a hospital at home model. And through telehealth and remote monitoring services that Avinola described, there were really, it was acute level hospital care that was being provided in patients' homes. And that was done in part to alleviate from surges from COVID. And telehealth has really helped keep if you do a telehealth visit before you go to the emergency room, you can avoid backups in the emergency room. So we've seen the real value of this as a hospital service, not just as a physician service. One of the things that the Congress did when they extended telehealth past the PHE, the pandemic, for physician services through 2024, they did not do that for hospital-based physicians or hospital-based care providers. And so there's a distinction. Some telehealth was extended, but not all of it. We would actually support extending all of it because there are a number of caregivers that are part of the care team with physicians, whether that's advanced practice nurses, some therapists, where they need to be able to continue that as well for certain types of patients. And so we would actually recommend further extending the expansion of telehealth because of its effectiveness, to include not just the physician side, but also some of the hospital-based provider telehealth services as well.
Thank you. So, question here: we hear about surprise billing, and it's certainly a major concern for many residents, especially in rural America, who, when they inadvertently go and visit a out-of-network provider, what would you guys suggest being done to prevent these surprise billing for patient needs needing care? And so I'll begin with Don on this one.
Sure. This is a tremendous concern and problem that I think it's a real challenge, because while we may have the best healthcare system in the world, it also is probably the most complex. And there's a lot of paper flow and electronic flow, and we don't have a universal coverage plan. So when you don't have that, you're going to have certain payers who cover some providers and not others. And one of the challenges of going to an out-of-network provider is when you don't know you're going to an out-of-network provider. So you may be going to a hospital that there's a physician practice there that is not a participating provider, or maybe they were, but then something changed with the network, and now they no longer are. So I think this is a real concern, and I think it's one of the things that hospitals can do is to try to ensure that the physicians working there, to the extent possible, and I think in rural hospitals maybe a little bit easier than in urban hospitals, to make sure that those rural physicians that are working in a rural hospital are part of the network that the hospital is in. But that means plans have to be willing to recognize that providing care in a hospital setting in rural America means that they have to give on negotiations as well. And I think that's one of the challenges that we have, is working with health plans and making sure that they are providing an adequate network. We hear about network adequacy as a challenge all the time. And in rural America, there's already a shortage of care sometimes. We've got to make sure that the network includes the available providers. So I think that's one thing that healthcare health plans can do. I think the other challenge that we have is around prior authorization and some of the delays that health plans put in place, or the denials that they put in place. And CMS and the Medicare agency has put on 2 new regulations that would try to address prior authorization. And the reason that's important is because it's a covered service, right? And when it's not, when you think something's covered and then they say, oops, you didn't get prior authorization, that's what a patient would consider a surprise bill. That's what the physicians in the hospital considered denying appropriate care. So I think getting CMS to finalize these regulations, and they already did one that will improve it for Medicare Advantage, doing that on the commercial side and for Medicaid, which they've got a proposed rule out there. I think that kind of the lines they're drawing around what is appropriate prior authorization and transparency around prior authorization is another way of preventing surprise bills that really are harmful to patients when they get them.
Carolyn.
I would agree with Donald on some of the prior authorization. We also have challenges with medical necessity. What is actually a covered service, when for our services, we don't air ambulance, we don't have any knowledge of who we're picking up. We don't make the call. It's a scene accident, it could be in the hospital. They say, the physician says, we got to get this patient out, and we go. And then later on, to have a health plan say, oh, we don't think that was medically necessary, or you should have gotten prior authorization, when we have to make these flights in 20 minutes or less. So that's, that is a challenge. And I think, continuing to need to have policies that understand why this is important, that, health plans cover these types of services and don't put these continued roadblocks in place. I think, on the surprise bills, there was, obviously the law that passed, I guess it was 2 years ago now, that bans balance billing or these surprise bills. And that's something that we were very supportive of, because the patient should never be in the middle of these disputes between health plans and and providers. And so that was a great, a great consumer protection. I think there continues to be some challenges, with the implementation, even after 2 years, with the independent dispute resolution process. We're hoping that CMS will be, stronger on enforcing, timelines and making sure that health plans, reimburse at adequate reimbursement. But I think the main thing that's really important is that patients were taken out of the middle, but obviously the more that we can make sure that patients don't face, large bills or anything is the most important thing. So hopefully, we can have continued enforcement by CMS to make sure that health plans, we think, do the job of covering those patients that should be covered.
Abanola?
And the only thing I will add is because we do have a value-based care model, we can spend more time with our patients to help them understand what services they have through use of our medical assistants, and just so that person just helping the patient along with, okay, well, this is where you're going to go and this is what your insurance covers, I think is super helpful. I think at the end of the day, at least from us, is communication and us being clear that we're not sure you should do the work, or it says here that this is what you have to do, I think really goes a long way, because as Donald said, sometimes you can get a prior auth and they say no, and they're like, this is a surprise bill. So just sometimes just talking to the patient of this is what's going to happen next, and spending that time with them, we found has been beneficial, at least on what we can do from the provider level. I think spending time with your patient, which is something I think all of us want to do, but it's hard to do, really helps as well, because you can sort of help them navigate some of the issues that may be upcoming for them. And like I said, because we're full capitated risk, we are invested in making sure that they do get the care that they need. And so the impetus has been, at least on us, to make sure our patients understand, what this means, or you may have to call, or giving them at least the resources and tools to make sure they have what they need in order for them to go forward with whatever it is that needs to be done, or whatever procedure that needs to be done, is one of the things that we are trying to do to make sure that we don't have patients, call us and say, I went to do this and this is what happened. And so we're trying to mitigate that. And so we're trying to do our part as well to sort of, improve our communication skills on, this is what's going to happen next. Oh, if you're not sure it's covered, you should call this number. And, sort of checking in on those patients as they go through and navigate this, as Donald said, hugely complex system on a very basic level.
I agree. And, as I mentioned earlier, there are a lot of providers, including myself, we deal with these issues every day, especially those that are out of network. So I certainly know that you guys are dealing with it at a much broader level. And so I can see where the frustration comes in from the patient and the provider in dealing and working with the insurer. And so hopefully we'll get to a point to where we can improve the communication, and kind of force some change from within to create a better system for all of us. So although they were ultimately excluded from the recent debt ceiling deal, there's always been these conversations about significant cuts to Medicare and Medicaid have been repeated proposals from individuals in Congress. And so what impact do you believe that these cuts will have to programs in rural healthcare, and we're giving rural healthcare access? And I'll begin with Carolyn, then Abanola.
Well, I think we all are going to say the same thing, that cuts to Medicare and Medicaid would be devastating to the healthcare system, since a large number of our people we serve are Medicare and Medicaid, particularly in the rural parts of the country. So it would be hugely devastating. Speaking just for air ambulance, already Medicare, as I mentioned earlier, under reimburses us, pays us less than 50% of our costs. Medicare is half of that. So, of our transports that we do, almost 70% are Medicare or Medicaid. So further cuts would result in, not being able to keep certain bases open. This would obviously reduce access. So I think it's, a huge issue. And, one of the things that we're working on right now is, Senator Bennett and Senator Blackburn, and also Congressman Estes and Del Bene have introduced legislation that would address the air ambulance fee schedule for Medicare. And that is something that we think is huge because, you fix Medicare, everything is sort of all tied to Medicare. It's the benchmark now. And I think it would really help in making sure that, we don't have to look at, oh, are we going to get paid enough in rural versus urban, or what type of payer mix we have? We need to find a way to preserve Medicare, and we need to find a way to make sure that we don't face these, it's like cuts by, little cuts, little cuts, little cuts, and they all add up, and they're having a huge impact. And I think we're seeing that. I think, and then COVID exacerbated it, and you saw how fragile this ecosystem is. So, against any more policy cuts there.
Avinola.
Yeah, I co-sign on everything Carolyn said. We are against any cuts there. And, as you said, it would be devastating. And I think the statistic is there are those in rural areas who are more likely to depend on Medicaid than those in urban regions. And so in a system that's already not ideal as it relates to reimbursement and how providers are reimbursed under Medicaid and Medicare, to then have additional cuts would be devastating. And, when we think about Medicaid, and I will not intrude on Donald's real house of hospitals, but these individuals will be uninsured, right? If we did the redeterminations, and a lot of people were thrown off of Medicaid, and now they don't have insurance coverage, right? And so it now makes it harder for all of us to provide care. And so now they're uninsured, and then we send them right to the hospitals. Now the hospitals have to deal with them, right? And so in the communities that we serve, both of these things are sort of lifelines for the hospitals and for the providers. And so for them to cut or reduce the access to Medicaid specifically would devastate, not even on the health side, but even if you think about like economically, right? If our hospitals are not getting paid, a lot of people work in the local hospital, whether it's, the person who goes in and cleans the rooms at night, whether it's the physician. And so for us, cuts to Medicaid are the wrong answer, and cuts to Medicare is also the wrong answer, because as it stands now, we're already trying to figure out ways, right, to provide care, even though the reimbursement is not the greatest for everyone. Which is why we in our company focused on value-based care, because we thought this was a new innovative way for us to provide care. And hopefully, and we can see that through the administration, right? They're doing more and more CMMI models, right, to sort of figure out ways to provide care within a construct that is created by CMS. But it is one of those things where, value-based care is not 100%. And so these are the systems that we have now. And so if anything, we should be improving it and expanding access as opposed to making cuts.
Don?
Well, you're right, Leader Daniels. There weren't very specific cuts to providers and to hospitals in the debt ceiling bill, but that doesn't mean they aren't talking about them still. And I can tell you that as more than a third of the healthcare dollar, hospitals are always being talked about as a provider to cut, because you can cut us a little bit and you get a lot of money. And so we're always on the defense. And the reason we're on the defense is because hospitals are already underpaid by Medicare and Medicaid. And as I mentioned earlier, every patient that walks in the door, we know we're taking a loss on. So that's why when Avinola talks about the coverage issues around Medicaid redeterminations and the ACA, they're so important, because we want to limit the number of uninsured that are out there. I would reference just two policies that right now we're most concerned about at the Federation of American Hospitals. The first one is a policy that was being considered by the Energy and Commerce Committee. And it's related to site neutral payment. And while there are certain services that can be done in multiple settings, when they're done in a hospital, they're done with the infrastructure around a hospital that is different than a physician office or an ambulatory surgery center. And there are proposals out there to reduce payments for any of these services down to the lowest payment. Well, that assumes that what the physicians are getting paid is enough. And I think Evinola may disagree with that. But I think the other issue we have is that hospital services are fundamentally different. Hospitals are a safety net in the rural area. They're taking uninsured, they're taking patients 24 hours a day, 7 days a week through an emergency room. They have many more compliance issues that they need to follow. And unlike other settings, oftentimes when a physician brings a patient to the hospital setting for care that they might be able to do in their office, they're doing it because that patient's actually sicker. And they want to make sure if they're doing an outpatient procedure that they've got the resources around them and the capacity around them in case something happens, because that patient may have several comorbidities. So this policy, and one of the policies that's being discussed, it wasn't introduced, but it was discussed by the Energy and Commerce Committee, would cut hospitals by $180 billion over 10 years. Now, for rural hospitals, that means that their margin in the outpatient side would reduce from a minus 30%, which is what they lose on outpatients coming to the hospital, to a minus 64%. So when we talked about earlier, the first question is how do we do this financially? It's really challenging. The second issue is related to a policy that is reversing, the Supreme Court reversed a hospital payment policy, outpatient hospital payment policy that was in effect for 5 years. So now they need to go back and pay certain hospitals for what they were underpaid because of this CMS policy. It's called the 340B drug reimbursement policy. And they paid them less than they paid all other hospitals for those drugs that they bought under this discount program. The question that we have is, when they pay them back, do they take the money away from everybody else to do that? And that's something that the government proposed to do in one of the early responses to this original lawsuit. What that would mean is an $8 billion cut to hospitals. Theoretically, we would not get that all at one time. But 89% of rural hospitals would be hurt by this, even if they benefit from getting the extra money from those 340B drugs where they were paid less. So it's a really big problem. It's very complex. I won't go into the details of it. But those are the two cuts that are on our horizon that we are laser focused on trying to prevent. And it's because it will devastate rural America if these go into effect in the way that we are concerned about.
Wow. I would say that, first of all, I'd like to ask the audience to give our wonderful, informative, and thought-provoking panelists all a virtual round of applause for the wonderful job that they did on this particular panel that dealt with healthcare in rural America. And as we do that, I'm going to turn it over to our founding board member, One Country, a mentor of mine, and to many, many others, our board member and founding member, Senator Heidi Heitkamp, to introduce our keynote speaker. And so thank you again for your participation. We had Donald May, Carolyn Mayle, Ebanola, Ania Kaye. So thank you guys for being with us, and we enjoy the discussion. I'll turn it over to Senator Heitkamp.